this is going to be kind of a lot of stuff. A lot of it's I'm going to go through pretty quickly because it's a lot for reference tables and stuff. But it's a lot of stuff, so we'll try to get through it and not bore you too much. We'll see. All right, so what we'll do is kind of just talk about cardiovascular. In effect, each part has overall hemodynamics. Review drug therapy fairly quickly and just stop and say some common points about each part you'll be looking for as a nursing staff, and then last part's discussing TPA, but it's kind of pretty quick at the end. So cardiac output in general. Cardiac output is defined as just the product of heart rate and stroke volume. And heart rate's defined, heart rate usually goes up and down, but what defines stroke volume is contractility, basically how well the pump works. Preload, basically the gas that's in the tank, and then afterload is like the force you have to pump against. So heart rate in general is affected by the autonomic nervous system. It kind of goes up and down. You usually have compensatory tachycardia for multiple reasons. Usually hypovolemia because you're trying to pump more fluid through in the same amount of time. So if you have less gas in the tank, you need to go a little bit faster. Hypotension, fever, so in sepsis, and then exercise, you have compensatory tachycardia. Slowing the heart rate to a point is a good thing. It increases filling time and optimizes coronary perfusion, but as you know, slowing it too slow is a bad thing as well. You can speed up, but you can go fast, and that's fine, but you don't want to go too fast. So usually a heart rate greater than 180 in a normal heart, or a heart rate greater than 120 in a diseased heart is a bad thing. Diseased heart meaning compromised ejection fraction. And then dysrhythmias like AFib can cause loss in atrioventricular synchrony, so if you're not pumping the atria at the right time and the ventricles are not there to follow, you're not going to move blood as efficiently. Contractility is just how well your pump works. It's defined formally as the force of ventricular contraction or the strength of the ventricular muscle. Basically, how well is your pump working? The number you'll see here is cardiac output. Cardiac output is not the same for everybody. It's based on height, weight, and size of the patient. So cardiac index is something we use usually. I know a lot in the intensive care unit, but in other places, cardiac index is going to be something that you'll see usually that defines your contractility. Preload is the amount of blood in the ventricle before it contracts, formally defined as the amount of muscle fibers stretch before systole, meaning the amount of fluid you have will cause that muscle to stretch a bit. Defined usually by CVP, you'll hear him talk about that. Invasively, if you're in the cath lab or in the intensive care unit, you'll see a PA end diastolic pressure, so a pulmonary artery end diastolic pressure or a pulmonary capillary wedge pressure. That'll show basically how much fluid you have in the ventricle at that certain time. This can be determined by total blood volume, so if you're bleeding out, distribution of vascular volume, so if people third space, they're very malnourished, and then atrial systole and synchronization, so you're not moving the fluid as well, so it can also back up. There's a law called Frank-Starling law, which I'm sure you've heard about plenty of times. Basically, it means if you give a volume challenge, you can increase stretch and basically increase contractility to a point. So basically, it's just showing that how preload's related to contractility. However, you can kind of see you have a benefit to a certain point. So in hypotension, if you give them fluid, they're going to have a significant increase in stroke volume if you give them fluid. Basically, meaning you stretch the muscle in the heart to a certain point. But if you get so far out, this benefit either flattens out, and if you extend this out, it will actually go down. So basically, if you can give a fluid challenge to a point. So basically what that means is contractility can be related to preload, but not if you overfill the heart. If the heart's already overfilled, if you give it too much fluid, it can actually cause a decrease in contractility if you extend this out a little further. Afterload is basically the force you have to pump against to get the blood to where it needs to go. So it's defined usually by mean arterial pressure, or if you invasively measure it by systemic vascular resistance. Resistance to flow and increased resistance leads to increased myocardial oxygen demand, which means if you've got a kink at the end of your hose here, the harder the heart has to work to get that blood to go where it needs to go. So you need a sufficient mean arterial pressure, but too much means you're kind of pushing it against this kink that you can't get past. This is a kind of a little thing I always like to look at, and it's something that really kind of defines everything. It's not going to talk about everything we talk about, but basically if you have a high or a low parameter based on one of these, it shows kind of how you would do it. So looking at it this way, if you have a preload that's high, you can either dilate the end so you can let the fluid move naturally, or you can diurese to get the fluid out of the body. If you have a low preload, if you don't have much fluid, you can give them volume.
So blood, colloids, crystalloids, whatever you would give them. If your afterload's a problem, so if you don't have enough afterload to pump the blood where you need to go, you give them a vasopressor. And if you had too much, you could dilate again or lower the blood pressure so the blood can move naturally to where it needs to go. And if your pump's the problem, if it's moving too fast to be inefficient, you can beta blockade or calcium channel block and slow the heart down. Or if it's not going as fast as it can, you can give an inotropic therapy, increase in force of contraction. And we'll kind of go into these all separately, but it's kind of a good little flow chart to say here's what your problem is if you assess your patient and how you would fix it at that time. So we'll kind of go to what the reason that I'm here for you is medications. Common classes of medications, you'll see this in a chart that you got in some of the material you'll have, just kind of what common classes we'll talk about and where they're used. The one I'll point out specifically is in heart failure, calcium channel blockers are not used because they can actually increase mortality. So if you have someone that has heart failure in general, you're not going to see them on diltiazem or verapamil or anything like that. You could see them on a Norvasc or amlodipine because it doesn't affect the heart, but this is just kind of what I want to draw attention to. You'll see a lot of these ones that don't hit the heart rate at all will not be used in dysrhythmia, which makes a lot of sense. And then a lot of your ones that are used in hypertension, all of them going to be used there because they're antihypertensives right here. So we'll talk about antihypertensives first. Good thing to talk about first will be receptor physiology. So a lot of these we're going to talk about are autonomic act on the adrenergic system. And the good thing to notice before you start is what it hits, and we're going to talk a little bit about vasopressors as well, and if you agonize the receptor and antagonize the receptor. So alpha-1 is a receptor that lies in the vasculature. So if you activate it, it'll cause a constriction, and if you block it, like an alpha blocker, you'll cause dilation. Alpha-2 can exist in two different spots, and that gets a little bit confusing. We'll kind of show a little bit of that later. It can be in the vasculature or the central nervous system, and depending on where it's at, it does different things. And we'll kind of talk about that a little more in detail when there's a picture to show that. Beta-1, mainly in the heart. The way to remember this is like I have one heart, so beta-1 receptors primarily rely on the heart. Agonizing this will cause tachycardia, and then antagonizing will cause a bradycardia. It can also exist in the vasculature, but it's a very small amount. So mainly you're going to see your effect here in the heart. Beta-2 is in the smooth muscle. It can be in the vasculature, but the way I remember this one, you have two lungs, so a lot of your beta-2 agonists are going to be working your lungs, so think of like albuterol. If you agonize beta-2, you're going to have a little bit of bronchodilation, so you give albuterol to help them breathe. Dopamine receptors kind of lie in the renal mesenteric arteries, and it's the idea of kind of renal dose dopamine, so low dose dopamine can actually cause a little bit of vasodilation, increase perfusion. And then dopamine works by hitting these other receptors as well. So the classes we'll talk about are vasopressors and inotropes, which is kind of the opposite of the antihypertensive, so the hypotensive medications. Alpha-1 antagonists, which we commonly call alpha blockers. Alpha-2 agonists will include like clonidine and medicines like that. And then beta blockers will all be kind of your adrenergic medications. So vasopressors and inotropes, these are going to be kind of going through pretty quickly. The way it's listed is mechanism. The number of plus signs is how hard it hits that receptor, usually 1 to 4. So you'll have some of them that hit some receptors very softly, some that'll hit them fairly strong. And the order I'm going to go in is from strict vasoconstriction, and to the end is going to be straight inotropic medications. So as we go through these, it's going to be, I'm working mainly on the vasculature to increase blood pressure, and then the last one I'm going to talk about is going to be I'm mainly working on the heart because it's not working at all. So phenylephrine or nisonephrine only hits alpha-1, so it's a strict vasoconstriction, does not hit your heart rate. So a typical indication you'll see for this is a hypotensive in patient with AFib or arrhythmia, ventricular arrhythmias, because you don't have to, anytime you stimulate a receptor on the heart, when you have an arrhythmia, it increases that arrhythmia. You'll hear them say sometimes like AFib causes more AFib. Once you're in it once and you keep agonizing that receptor, you can kind of go into arrhythmias again. So anytime you basically touch those receptors, to agonize them to speed up the heart, you kind of have an arrhythmia issue. So if you have someone that has an arrhythmia issue that's hypotensive and you've checked their fluid status and they're fine, phenylephrine is usually pretty good if you confirm you have no heart problems, or basically inefficient heart. Vasopressin, we didn't talk about vasopressin receptors, but vasopressin 1 receptors are mainly in your vasculature, so you can have peripheral vasoconstriction here. They're not in your heart, so it's going to be kind of like phenylephrine. You can use it for two different things. The ones we'll see most of the time is fixed dose for sepsis protocol, but Again, these are kind of doses for your reference. The main time you'll see this one is septic shock. Norepinephrine, so when we use Levophed, we see it all the time. It used to be, a lot of older practitioners you'll see, and when I first learned it was Levophed, leave them dead. A lot of people didn't want to use it. But actually, Levophed is one of the most recommended pressors and our main one we use all the time. Usually in septic shock, and it's usually first line in everything. The reason it works is it has vasoconstriction, but also speeds up the heart a little bit. And in a lot of your hypotensive patients, you're going to have a little bit of an inefficient heartbeat as well. So it helps a little bit, but not a lot. It doesn't cause the rebound bradycardia that a phenylephrine would, but it also increases your blood pressure. Epinephrine, so your adrenaline in general. Lower dose will hit more of the beta receptors, so it'll speed up your heart. So if you have someone with bradycardia, it'll work. On higher doses, it'll increase your blood pressure. A lot of times most of the time you'll see this as anaphylactic shock, as a sub-Q injection, but then also as a drip. But you can use it, a lot of times you'll see it post-code as well. Dopamine is the biggest one that's dose dependent. You can kind of look back at this. The lower doses will hit dopamine receptors and beta receptors. The higher you go, the more vasoconstriction you have. Usually you'll see this low dose symptomatic bradycardia. You don't see it usually this high, but sometimes you will. Dobutamine, so more of your positive inotropic. This is someone that has usually heart failure, comes in with cardiogenic shock. Mainly hits your beta-1 receptors, so if you think you agonize your beta-1, you're speeding up your heart, you're also increasing calcium influx and increasing force of contraction. And milrinone is the kind of the oddball. So what it does is it basically goes behind the beta-1 receptor and increases calcium influx into the cell through a phosphodiesterase reaction. Basically, someone that takes a lot of beta blocker comes in with cardiogenic shock, you'll see them use milrinone. So basically, you've increased calcium influx, increased force of contraction of the heart. Isoproterenol, so isoprel, you'll see mainly used by cardiologists. I don't see it a lot, but it's also mainly beta-1, so you're just increasing force of contraction. Sometimes you'll see oral midodrine used, not very commonly. Usually it's for orthostatic hypotension, people that are on dialysis therapies that need a higher blood pressure. The way I can define this is an oral phenylephrine. It hits your alpha-1 receptor, increases your blood pressure for a little bit of a period of time. Not that much, but enough to maybe do dialysis or enough for someone that they have persistent hypotension. For vasopressors, main thing I would say for you all is if you have a central line, use it. If you don't have a central line, watch for extravasation a lot because you'll see kind of like a darkening. If they complain of any kind of pain at all, you may have extravasated it. And if you have something that actually constricts and stays in your sub-Q tissue, you'll see this tissue start to necrose. And if you have any kind of sign with that, you can use a drug called phentolamine or a regitine. So that's something that basically dilates the alpha receptor and it reverses the changes that goes on. And there's protocols where you inject it sub-Q around the area. So it's just important to use a central line if you can to avoid extravasation, because extravasation of dopamine, if you ever want to Google a really nasty picture, look at that. You'll see like people's basically arm about the yay far just be dead all through here. Use the least amount required because they're not benign. You can actually have hemorrhages for increasing blood pressure, maybe easily in the brain. You can have arrhythmias if you use too much beta receptor. You can have headaches, nausea, vomiting. And then each agent has an ideal niche. So basically your patient defines what drug you would use. It's not like, oh, their blood pressure's low, I'm going to use any vasopressor on this list. If you have someone that has a lot of dysrhythmias, you could use phenylephrine. If you have someone that has a bad heart, you don't want to use phenylephrine, you want to use something that actually increases the heart rate as well. So just kind of as a clinical or critical thinking point, each agent has an ideal area where it could be used. So we'll go kind of to more of the oral medicines and the antihypertensive medications now. So alpha blockers. These are some of them. You probably won't hear much of these because you don't see these commonly, but you'll see Cardura, Hytrin a lot. A lot of people will throw Flomax into here because it's a selective alpha-1 blocker. So here's kind of where you can see alpha-1 exists. So this is your smooth muscle. This is your vasculature. So when you agonize this receptor with a norepinephrine or a chemical like that, you'll basically go in here and increase contraction. So alpha blocker, you're going to block this and cause vasodilation. And we'll get to the alpha 2s in it. There's just a picture of the whole Synaptic, so this is your neuron secreting or putting out norepinephrine, and this is where it acts on your smooth muscle, so your vasculature here. Alpha-1 antagonists affect norepinephrine release and decrease blood pressure. Adverse reactions you'll see a lot are postural hypotension. You're causing vasodilation, so it can worsen heart failure because you're not hitting beta. You're basically lowering blood pressure with just alpha alone. Doxazosin, so Cardura and Hitrin and Minipress are usually alpha-1 selective. So they're used for general hypertension and usually BPH. Someone that has a prostate issue, you'll see them on these medicines a lot. Phenoxybenzamine and phentolamine are non-selective. So they're used for a treatment of a norepinephrine secreting tumor called a pheochromocytoma. You won't see these a lot. I rarely see these because a lot of people don't have this. It's a rare condition. But what a pheochromocytoma is a tumor that secretes norepinephrine. So you can't just block one receptor. It's going to hit the alpha-2 receptor. And if you go back here, you have a small amount of alpha-2 receptors on the vasculature here that can actually cause blood pressure increase as well. So if you block this just one, it still can get hypertensive by hitting this right here if you have an overload of the system of norepinephrine. So if you have a non-selective blocker like phenoxybenzamine right here, you block both, and that's how you treat a pheochromocytoma in that regard. Nursing pearls for these, you have something called a first dose phenomenon. So the first time you ever give this medication to somebody, like if you ever start on anybody, it can actually cause a really big drop in blood pressure. A lot of people react differently. So it's important to watch them the first hour they take it because they could easily drop 30, 40 points in blood pressure if they've never tolerated it before. And it's not always just the drug, it's just how much they give because they're usually the max dose of any of them is like 5 milligrams. So if you start them on like a 3 milligram or a 4 milligram dose, they could just drop really quickly. It's best taken at bedtime because of this postural hypotension, so you don't give it to them in the morning, get them up in an hour and walk them and then get on the floor. Usually a lot of these times they'll take it at bedtime because that hypotension will exist while they're laying down. Caution use with other vasodilator therapy because you're going to have an increase in hypotension. And then phentolamine, we talked about before, can be used for extravasation. So alpha-2 agonists. So this is where it gets a little bit confusing. So this is clonidine. Methyl-dopa is usually used for pregnant patients, but we'll talk a little bit more about clonidine. So alpha-2, we talked about a minute ago, is on the vasculature, and ideally you think you would block this. But there's a presynaptic alpha-2 receptor that if you agonize will actually decrease the amount of norepinephrine release into the synapse. So if you go back basically before the receptors and decrease the release of norepinephrine, it acts as an antihypertensive in that regard. Does that make sense? So basically I'm decreasing the amount of norepinephrine. I don't agonize these receptors near as much because I have less material here to agonize these receptors with. And that's how clonidine works in general. So if you suppress sympathetic stimulation, decrease blood pressure. Clonidine, you'll see it's a rapid onset, drops the pressure pretty quickly. Usually a 2 to 3 times a day drug, and it can actually exist in a patch. Some people wear patches, last for a week or so. Methyl-dopa works a lot like clonidine because its metabolite works similarly to it, and it's usually the drug of choice in pregnant patients. You'll see a lot of, it used to be used all the time in pregnant patients. We have a few more now that can be used in pregnancy, and you don't see methyl-dopa as often, but that's the one that if anybody ever asks you what's the drug of choice in pregnant patients, it's methyl-dopa. Clonidine can be used for anxiety, other issues besides hypertension. It's just important to kind of know that. Like, just because you have somebody on a low dose of clonidine doesn't mean they're always hypertensive. They can be taken for sleep. They can take it for other things like that. Abrupt discontinuation of these medications can lead to severe reflex tachycardia and hypertension. Very similar to beta blockade. If you stop clonidine like that, you can see their heart rate go up super quick. Their blood pressure can go up to the 160s, 170s. So it's just important if they're on these at home, if you notice that, it's important to kind of continue those. All right, beta blockade. We'll talk a little more about these. So I say common members because there's like 20 or 30 different kinds of beta blockers. A lot of them are older. We don't see a lot anymore. The ones you'll see more often are listed right here. You can use beta blockers for a lot of different things. Hypertension, tachyarrhythmias, compensated heart failure, not for exacerbations. The reason that is if you have a heart failure exacerbation, you're having a problem with the heart beating anyways. So the last thing you want to do is slow it down. If you're in compensated heart failure, it's important to slow it down because you don't want to overwork, and basically with heart failure, you hypertrophy if you overwork. right? You have a left ventricular wall thickness increase, you have decreased ejection fraction. But if you are in decompensated heart failure, you don't want to use it, if that because you're already having problems. Other uses you can have, usually for propranolol, sometimes migraine prophylaxis when it's stage fright. You can use it for portal hypertension, so people that have cirrhosis, you use non-selective beta blockers to decrease that. You can use it for thyroid storm because propranolol can actually help a little bit with that. Agents differ based on 3 different factors. So selectivity for the beta-1 receptor, intrinsic sympathomimetic activity, and then just other mechanisms of action they have. So beta-1 selectivity means it just works on the beta-1 receptor, which is good sometimes because you want it, they're the ones that are going to control your heart rate better. The rule of thumb is if the generic drug name starts with the letter in the first half of the alphabet and the generic drug name ends in just OLOL, it's going to be beta-1 selective. And that's kind of a hard thing to, basically your first half of your alphabet. So metoprolol is usually beta-1 selective. Atenolol is beta-1 selective. Bisoprolol, esmolol. Drugs like that are beta-1 selective, which is good. It's not going to drop your blood pressure as much, but if you want to use something for like rhythm control, it's a really good thing to use. Intrinsic sympathomimetic activity is basically a partial agonist effect that mitigates your response. So it's more tolerable for people that have exercise issues, people that exercise or is prone to hypoglycemia, so beta-2. Sometimes you can have like issues with increase in hypoglycemic side effects with beta blockers. So intrinsic sympathomimetic activity usually has, there's one called ACE-butylol that does that. Special effects are important. If you have someone that's really really hypertensive, carvedilol or abedolol also block the alpha receptor along with being a beta blockade. So you can actually decrease blood pressure fairly significantly more with carvedilol or labetalol. Nebivolol releases nitric oxide, so you have another like a vasodilator effect. So you have like a synergistic relationship with dropping blood pressure. You'll see a lot of people on Coreg, and the reason that is because they're super hypertensive and they have heart rate issues, so it actually helps out in that regard. Obviously, you're going to have issues with bradycardia and heart block if you take too much of it. Asthma and COPD is mainly for non-selective beta blockers, because if you block that beta-2 receptor, you can have a little bit of a bronchospasm, like thinking of the opposite of albuterol, basically. And then non-selective beta blockers can have the issue with diabetes because they feel like they're basically low blood sugar, so it can affect symptoms of hypoglycemia. Kind of the same thing down here. There are 2 forms of metoprolol. This is a big thing I always run across as a pharmacist that patients don't realize, and then that some like healthcare providers don't notice as well. Like let's say, well, I take metoprolol. It's important to say, well, what form do you take? Because there's metoprolol tartrate, which is low pressor, which we commonly use in the hospital. It's a twice or 3 times a day drug. And then there's metoprolol succinate, which is basically your extended release metoprolol, or Toprol XL. So you have people that say, well, I take metoprolol 50 twice a day. Well, it's important to know which one they take. If you give them metoprolol succinate twice a day and they're not used to it, it could drop their blood pressure a lot. Or if you give them metoprolol tartrate once a day, you're going to have an issue with basically it's going to wear off quicker. So monitor your PR interval. So usually your rule of thumb is a PR interval of greater than 0.2 is usually a parameter for holding it because you don't want to develop an AV block. Don't stop these drugs abruptly because, unless they have a super big problem like the PR interval, because you're going to have a rebound tachycardia. You've blocked these receptors for a long period of time. So when you first start a beta blocker, you have beta-1 receptors and the heart will develop more, ideally, to kind of counteract this. Once you have a full beta blockade, their heart rate's controlled. But if you stop them, you have all these extra beta-1 receptors that won't be agonized. So everybody just all the norepinephrine comes here and has a big party, right? So then you have tachycardia. So basically, you have a rebound tachycardia if you stop beta blockers like that. So ideally, if you're going to stop somebody on those, or if somebody's going to stop on those, you would wean those off. 3 beta blockers specifically are beneficial in CHF. So if you have CHF patients, they're usually on one of these. Mainly because they studied it. They're the ones they studied in the trials. Ideally, all the beta blockers are going to work in every patient for heart failure, but these are the 3 that are proven to work. And then beta-1 selectivity may be lost with increasing doses because you just override the system. So if I give 200 milligrams of metoprolol twice a day, which can happen, you're not always just going to be beta-1 to selective. It's going to lower your blood pressure as well and probably hit some of the others. So basically, with any kind of drug, selectivity is usually lost with the higher doses. But if you just put them on a low dose of a selective drug, it's just going to hit the beta-1 receptor usually. So nitrates, so your Mdur, nitroglycerin. Basically how it works is you have nitric oxide, which basically leads to dephosphorylation of your myosin chain. So basically your muscle's going to relax in that way. You're going to use it for hypertension, and most commonly you'll see low doses used for prophylaxis of angina and active treatment. Usually your Mdurs for people that have angina at rest. Using caution with a patient with head trauma and cerebral hemorrhage, because you don't want to cause basically so low of a blood pressure that if you have an active hemorrhage would expand. Headache is a big common thing with nitro. If you've run it a lot, you know that people get this raging headache after a while. It's a so nitro is a vasodilator, usually used for chest pain or hypertension. Not as commonly for hypertension, but usually for chest pain. Tachyphylaxis is a huge thing. What that means is basically it works for a little bit, but you develop tolerance. If you ever put people on nitro, you'll notice you'll put them on a little bit, and then like the next day that doesn't even do anything for them. You have to keep turning it up till you get to max, and then that doesn't work for them. That's why, honestly, you don't use nitroglycerin a lot long term. So when you give them nitrates, you'll notice there's a nitrate-free interval. We usually give it once a day, fixed extended release, or if you give them like a isosorbide dinitrate or an Isodil, you give it like 9 and like 2. The idea is you want that nitrate-free interval so you don't cause this tachyphylaxis if you give it around the clock. If you ever get nitroglycerin paste on the chest, they'll say give it for a bit and then take it off for a couple hours, then put another one on, right? You don't do it 24 hours around the clock. The reason it is you develop this right here. So tachyphylaxis means basically your dose you used before doesn't work anymore. And then you also decrease your side effects by taking it off for a period of time. So your other vasodilators, main one you're going to look here and see is hydralazine. Nitroprusside, so nipride you can use. We don't use it a terrible lot. Minoxidil is basically a medication you'd use for someone that's tried every other blood pressure medicine and it doesn't work. So this is all your mechanisms of vasodilation. So you can see your alpha blockers right here. You can see nitrodilators. So we talked about nitroglycerin right here. We're going to talk about the RAS system and ACE inhibitors in a minute. You got direct acting, which is basically we don't know how they work, but they work somehow. And then your calcium, potassium channel blockers and things like that will work right here, and we'll talk about a little bit of those. So they act directly on the muscle, and basically you dilate arterioles. Nitroprusside is something you use for really bad hypertensive crisis. A lot of things that's taken, used to be used a lot more, but now we can use a lot more cardine or nicardipine more. The reason it is nitroprusside has some real bad side effects, including in renal patients cyanide toxicity. Your drug breaks down into a cyanide byproduct, you have buildup of cyanide, you have methemoglobinemia, and a crisis in that regard. So you basically maintain a low dose as possible, don't use it in renal patients, don't use it in hepatic patients, it's kind of like, let's just not use it really anymore. But you'll have your patient that responds to it fairly well. I've probably used it in the last 3 or 4 years twice or 3 times. So it used to be a lot more common than it was, or it is now. Use it for hypertension, and hydralazine plus a nitrate in usually African American patients will use it in heart failure because you're basically relieving that afterload reduction to pump the blood where it needs to go, where it doesn't back up. Not one of your top 3 really therapies, but can work. Reflex tachycardia is a big thing because basically you're relieving anytime you don't have a full beta blockade and you vasodilate, the heart will beat faster in response. Agent-specific minoxidil, topical minoxidil, fun fact, is Rogaine. So the reason if you take oral minoxidil, you have increased hair growth. That's why. So monitor blood pressure closely because these will drop it super quick, specifically minoxidil. Monitor extremely carefully conditions that may lead to decreased fluid volume. The reason you say that is if you have someone that's dehydrated and you give them a vasodilator, their pressure is going to go down to the floor. So basically, if someone that's dehydrated, you just want to monitor and maybe hold this for a bit. And that's for basically any blood pressure medicine, but specifically vasodilators. So calcium channel blockers. Norvasc, you're going to see a lot of medicines you remember. Diltiazem, seems like we've been on diltiazem shortage forever, but we've hopefully getting it back soon, verapamil, which you don't see much anymore. How calcium channel blockers work is basically decrease the calcium influx into the cell. Calcium in the cardiac myocyte is your main source of fuel. So if you decrease your calcium influx into the heart cells, you decrease basically force of contraction. If you decrease calcium influx into the smooth muscle, you decrease vasoconstriction. And that's important when we get to this next little chart right here. Not all calcium channel blockers are the same. Amlodipine, so your dihydropyridine calcium channel blockers, the ones that end in INE here, so Norvasc or amlodipine, nifedipine or Procardia, so nicardipine, so cardine when you use a drip, you work 99% on the vasculature. So that means mainly your effect is on vasodilation, and it doesn't have effect on like bradycardia or anything like that. When you get to diltiazem, it's half and half. So you're going to have a decrease in blood pressure, but you're also going to have a decrease in heart rate. So that's why when you use, diltiazem drips in people that have AFib. And verapamil works mainly on the heart. So usually it'll drop your heart rate pretty significantly when you give that. So it's used mainly